بسم الله الرحمن الرحيم. رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقه قولي. صدق الله العظيم. Assalamu alaikum, esteemed guests, distinguished speakers, and valued attendees. I'm pleased to welcome you all to the AI in Healthcare virtual conference. My name is Ahmed Saleh Balooshi, and I am your moderator for today's event. My bio is displayed, so I won't go through all of it. But to summarize it, my ultimate area of expertise relies on the Industry 4.0 technologies. In addition, I'm certified in data science, AI, blockchain, and advanced cybersecurity. Inshallah, this session will be beneficial for everyone. We gather here today remotely, yet united in our shared interest and commitment to exploring the transformative power of artificial intelligence in the healthcare sector. Your presence, whether as speakers, professionals, or enthusiasts in this field, enriches this event and fosters an environment of learning and collaboration. This event is not just a conference. It inspires insights into how AI revolutionized healthcare under the esteemed patronage of Her Excellency Dr. Mariam Jalahma, the CEO of Government Hospitals. We are set to embark on a journey of a discovery and discussion. We aim to explore how AI's innovative applications reshape patients' care, medical research, and healthcare operations. Today, we stand at the edge of a new era where technology and healthcare join to create better outcomes for medical service worldwide. Now, we are honored to introduce a recorded speech by Her Excellency Dr. Mariam Jalahma, CEO of Government Hospitals. Her insights on AI and healthcare are invaluable, reflecting her extensive expertise and leadership in this field. So we will be just displaying a video for this speech in a few seconds, inshallah.
بسم الله الرحمن الرحيم. سعادة الدكتور عبد الله بن ناصر النعيمي الرئيس التنفيذي لمركز ناصر للتأهيل والتدريب المهني، سعادة الدكتور جاسم حاجي المستشار التنفيذي لمركز سمو الشيخ ناصر للبحوث والتطوير في الذكاء الاصطناعي وعلوم البيانات، الإخوة والأخوات الكرام، السلام عليكم ورحمة الله وبركاته. إنه لمن دواعي الفخر والسعادة أن نلتقي بكم اليوم في هذا المؤتمر المعني بالذكاء الاصطناعي في الخدمات الصحية. وبداية نتشرف أن نرفع أسمى آيات الشكر والتقدير إلى المقام السامي لحضرة صاحب الجلالة الملك حمد بن عيسى الخليفة عاهل البلاد المعظم حفظه الله ورعاه، ولمؤازرة صاحب السمو الملكي الأمير سلمان بن حمد الخليفة ولي العهد رئيس مجلس الوزراء حفظه الله على الدعم اللامحدود الذي يحظي به القطاع الصحي وبما يتماشى مع مبادرات التطوير الشامل التي يشهدها هذا القطاع. انطلاقا من إيمان المملكة الواسع بنهج التنمية المستدامة وتجسيدها في كافة أهدافها التنموية، كما يطيب لنا أن نشيد بالجهود الموفقة لسمو الفريق الركن الشيخ ناصر بن حمد آل خليفة ممثل جلالة الملك للأعمال الإنسانية وشؤون الشباب رئيس مجلس أمناء مركز ناصر للتأهيل والتدريب المهني، والتي أسهمت في إطلاق المركز خطته الاستراتيجية 2025 الهادفة للتحول إلى مدينة علمية تحتضن التحول الرقمي، لتكون بمثابة الوجهة المثالية للتعليم التكنولوجي والمهني للشباب البحريني في تنمية مهاراتهم وخبراتهم والدفع بها نحو آفاق أرحب في التميز بدعم وتمكين القيادة الرشيدة في المملكة. الحضور الكريم، تولي مملكة البحرين أهمية بالغة لتوفير الخدمات الصحية وتعزيز الشراكة وتبادل الخبرات والإمكانيات بين مختلف القطاعات والمؤسسات الحكومية وفق منهجية ترنو إلى النهوض بالقطاع الصحي في مملكة البحرين، ومما لا شك فيه أن توظيف الذكاء الاصطناعي في مجال الخدمات الصحية سيسهم بشكل فعال في رفع مستوى الكفاءة والخدمات الصحية التي تقدمها المستشفيات الحكومية وفق أعلى المعايير. الإخوة والأخوات الأعزاء، أن توظيف تقنيات الذكاء الاصطناعي في العمليات الإدارية والصحية المختلفة، والتي تتيح جملة من الحلول الذكية أبرزها أنظمة الاستشعار والتحكم الخاصة بظروف التخزين للأدوية والمكونات العلاجية، بما يسهم في الحفاظ على فعالية الأدوية وتركيزها، بالإضافة إلى استخدام تقنيات التنبؤ بكميات الأدوية اللازمة وعدد المرضى الزائرين للمستشفيات من جهة، واستخدام روبوتات المحادثة في التعامل مع الجمهور، وتقديم الاستشارات في تطبيقات متقدمة، وتوظيف لوحات التحكم الذكية. كل ذلك سيكون له الأثر الكبير في تغيير مفاهيمنا الحالية عن تقديم الخدمات الطبية. الحضور الكريم، ولا شك أن إشراك الذكاء الاصطناعي فيما يتعلق بالمعالجة الاستباقية للأمراض المزمنة والأمراض الوراثية والأورام من خلال تقنية التنبؤ التي تساهم في الكشف المبكر عن الأمراض وتحديد البرامج العلاجية المناسبة وعدد الأطباء اللازمين لعلاج المرضى من جهة، وسيسهم في رفع مستوى الإعداد والجاهزية وتقديم أفضل الخدمات الطبية على أعلى المستويات وأفضل الإمكانيات. وختاما، لا يسعنا إلا أن نشد على أيديكم الساعية لتسخير العلم في خدمة وراحة ورفاهية البشرية، سائلين الله سبحانه وتعالى لنا ولكم دوام التوفيق والسداد.
Thank you for Her Excellency Dr. Mariam Jalahma for her motivational speech about the goals and the objectives. Now, next, let us welcome Dr. George Cheriyan, Corporate CEO of the American Mission Hospital in Bahrain, and a renowned expert in neonatology. His remarkable healthcare journey and vision for quality, affordable care are genuinely inspiring. Please let us hear him with his speech. Again, it's a video speech. Until it's prepared.
Good morning, everybody. Your Excellency Mariam Jalahma, the CEO of the Government Hospitals of Bahrain, Dr. Jassim Haji, the Chairman of the Conference and President of the International Group of Artificial Intelligence Community, and all of the organizing team that put together this wonderful conference. Thank you for your invitation to speak to you a few words from my perspective of being a physician and a healthcare provider at the American Mission Hospital here in Bahrain. The second virtual summit on AI in healthcare is itself one of the indications of how quickly we have all adjusted and adapted to what is a future that is well upon us, accelerated by what the COVID did to all of humanity over the last 2 years. Today, we are forced to adapt to technologies that are beyond what we have envisaged or imagined over the last few years ago. I recently read in 2008, fewer than 1 in 10 hospitals had adopted an electronic healthcare records. Today, it is mandatory that any modern healthcare institution has to have an electronic healthcare records, and often patients have access to their own electronic healthcare records through the web. There are lots of reasons why physicians were slow to adapt to having electronic healthcare records, because a lot of physicians of the older time were technology agnostic, and to adapt to a newer technology that interfered with dealing with patients became a big obstacle in how artificial intelligence and electronic healthcare records was initially embraced. However, this all changed with COVID, when we were forced to go on to telehealth as a medium of consulting with patients remotely, when face-to-face contact was just not possible. Today, most of the developed countries have digitized their healthcare records, and patients have access to their own healthcare records. The AI market, as we know of today, was in 2021 around $11 billion worldwide. And by 2030, this is set to exponentially increase to close to $190 billion by 2030. And this is at a compound annual growth rate of close to 37% from 2022 to 2030. Healthcare AI is basically the application of artificial intelligence to augment human intelligence in the provision of medical services and to the safe and efficient deployment of healthcare services to the public. In this domain, multiple modalities come into play when we talk about artificial intelligence. Machine learning, large and often unstructured data sets, how that is analyzed, the use of advanced sensors in monitoring patients both in the hospital settings and at home, natural language processing NLP, which has become fairly much more routine, the use of robotics, VR and AR, both as augmented realities that will help shape the future of healthcare. While there are many opportunities, there are also indeed great many challenges. Firstly, I would talk about how AI might augment health administration. 25% of the cost of healthcare provision rests in the admin area, and certainly a lot of automation and today's generative AI can save a lot of these costs, which are repetitive costs that can be done by AI rather than deploying humans. The other space where AI is going to have a significant impact is in the use of clinical applications, both in surgery and the use of robotic surgery in advanced surgical procedures. And finally, in the space of training and research. Most surgeons now train on simulation models which are AI generated and advanced AI generated models where most of the practice is done so that the performance on real patients is actually operationalized to produce the maximum benefit for patients. In this conference today, you will be deep diving into the very many aspects of AI and its applications in healthcare, and I cannot but end this few words by reminding everyone cybersecurity is a constant threat when we go more and more into the digital space. And so this is particularly important in the healthcare space where data has to be protected and preserved. So I hope and wish that you would have a wonderful conference in the second virtual summit. Thank you.
Thank you very much, Dr. George. Inspiring. And yes, I do agree with you 100% that the cybersecurity is something very, very important. Every leader needs to consider it during any digital transformation using the Industry 4.0 technologies. Next, we have our chairman of this conference and the president of the International Group of Artificial Intelligence Community, Dr. Jassim Haji, who will be delivering his opening speech. Dr. Haji expertise, and it's already displayed on the screen. Dr. Haji's expertise and leadership in AI and its application in healthcare and in various fields are widely recognized, either in Bahrain or GCC or even in the Middle East. And his contribution today is eagerly anticipated. I would like to welcome Dr. Jassim and his opening speech. The floor is yours, Dr. Jassim. Thank you very much.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, dear Ahmed, and other supporting AI conferences in the region. Would like to start with also appreciating the speeches from Her Excellency Mariam bin Jalahma, CEO of Government Hospitals, and His Excellency Dr. George, CEO of American Mission Hospitals. It shows also the depth of the support and awareness amongst the public and private hospitals and healthcares in the Kingdom of Bahrain. I would like also to take this opportunity to thank our speakers who are joining us from the United Arab Emirates, from the Kingdom of Saudi Arabia, and of course from the Kingdom of Bahrain. Ladies and gentlemen, this is our second Bahrain's international conference on AI in healthcare. The last one was over a year ago, and it also shows the pioneership of the kingdom in adapting an AI in various fields. Not to mention, we also have annual conferences, virtual or physical, and AI in sports, AI in judiciary, AI in parliaments and governance, and many other applications of AI. Started all the way from year 2000, which also displays another angle of awareness of AI. This virtual conference is also supported by His Highness Sheikh Nasser's AI Research Development Center, the biggest AI center in Bahrain, and one of the biggest in the region, developing AI solutions, not to mention also AI solutions in the healthcare that has been developed by young graduates from various universities in the area of the healthcare, predicting diseases, medicine awareness and development, and what to do with the shadwells and the equipment used in the major hospitals in the kingdom. Of course, we always can develop more and see a lot of ready-made solutions, but it is very unique to see customized solutions by the scientists around the GCC in the area of the healthcare, and we have some of the unique ones in this conference. We'll be speaking to everyone else and probably describing their experiences plus the theoretical perspective that is available nowadays. I will not hijack their speeches, but of course, the generative AI, which has multi-dimensions, not to mention Gemini, which we are expecting also to play a major role in the healthcare generative AI, and many other predictive or analytical solutions that the team will be sharing. The issue here that we would like to address that we all have to adapt to AI in healthcare. Now, we could be pioneers today, but the followers tomorrow. And we in the kingdom and in the GCC are probably leading these initiatives in the Middle East and Asia in terms of AI usages. So without further ado, I'll give back the floor to Ahmed to introduce our consequent speakers and wish everybody good luck. And thank you again for all participating and being part of it.
Thank you, Dr. Jassim. That was a wonderful speech. And thank you for arranging this conference for the people with your expertise. I know you have done it with so many other fields also. So this is to send an awareness for everyone in our region that AI is coming strongly and we need to adopt it. AI is only about adopting the new innovations that's coming in. So now, in addition to these keynote speeches, we have a lineup of 16 speakers who will each present a 20-minute session. These sessions are designed to provide a comprehensive overview of various aspects of AI in healthcare, showcasing the latest innovations, research finding, and real-world application. My first speaker, I would like to ask her to join me and switch on her camera. Allow me to introduce our first speaker, which is an esteemed assistant professor at Khalifa University, Dr. Aamna AlShehhi, who is an expert in biomedical engineering, electrical engineering, and computer science. She holds bachelor's in software engineering, a master in computer and information science, and a PhD in interdisciplinary engineering, focusing on machine learning and AI. Wonderful. Dr. Aamna's research spans statistical analysis, big data, and AI application, and weather forecasting and social media analysis. She has contributed to medical AI at Khalifa University, MIT, and Imperial College London, working on melanoma detection and cancer genomics projects. Her speech title is Harmony and Complexity, Exploring the Synergy of AI, Big Data, and Biotechnology. Please, all the best, Dr. Aamna. The floor is yours.
Thank you so much. I'm trying to share my screen. So Okay, can you see my screen?
Yes, we can see your screen. Right, please.
Okay, thank you so much. So thank you all for having me at the second virtual summit on AI in healthcare. So welcome to my talk about harmony and complexity. Just give me a minute. Yeah. Okay, harmony and complexity, exploring the synergy of artificial intelligence, big data, and biotechnology. So in today's talk, first I will give you a brief introduction about what we mean by biotechnology, then what we mean by big data, biological data, focus on biological data, and then a brief about AI. I'm sure everyone aware of what we mean by AI, then like how those three terminology came together, and then I would talk about two research work that we did at Khalifa University. Finally, we will talk about future outlooks, possibility, and conclusion. So first, biotechnology. So biotechnology is actually the use of biology to develop any product or method that can help human health and improve human health and society. And this fields actually have like many various, it's multidisciplinary fields that come across with other fields like molecular biology, genomic, genetic engineering, chemistry, informatics, and bioinformatics. So when we talk about biotechnology, it's actually a color-coded field in which like there are different colors that indicate like the focus of this domain. So if we said like red biotechnology, that means the biotechnology techniques will focus on medical domain. For example, if we have blue, that means we focus on marine life and environment. Gold, that means it's bioinformatics and that aspect. And in this talk, for sure, I'll focus on red biotechnology, which is actually the focus on my research team here at Khalifa University. So red biotechnology is actually covered different applications of biotechnology that related to many applications like clinical trials, vaccine development, disease research, drug development, and many others. So now, like, it's just brief about like biotechnology. Let's talk about big data and what we mean by big data. So big data is a terminology that refers to having a huge amount of data, and those data can be structured and non-structured. So when we say a structured data, that means it's well organized like image or table, and unstructured data is something like a non-Euclidean space, like a graph-based structure similar to molecular structure, or for example, SMILE representation of a drug. So we have like a part of having a structure and unstructured data set. Those data, we collect them. We collect a huge amount of data over time, and the quality of the data change over time. So this is a general introduction to the meaning of big data. So if we talk about big data, biological data, so biological data actually focus on the data that generated by biological or living organism. So when we talk about focus on biotechnology, we talk about genome data, RNA, DNA, sequence data, literature data that related to gene or different information about gene, protein interaction, pathway. So all those biological data are what we focus on biotechnology domain. And when we look at all those data, we will notice we call them first omics data. And those omics data actually differ in terms of the representation. Are we focused on DNA, RNA sequence, or are we focused on the protein structure? So for DNA, RNA sequence, we have like, it's a linear domain. However, if we talk about the protein, we have the 3D representation of the protein. And interestingly, like those gene expression or protein structure differ in terms of what type of cell that we use to extract those information. And even like the expression of those organs or genomes are differ across the age, and it's related to the environmental factor. So other types, so here I present like different biological data. So we can see microarray data, protein structure, DNA, RNA, protein 3D representation or amino acid representation, and SMILE. So we can see like those biological data exhibit the concept of big data. And when we talk about biological databases, actually there are two big publicly available databases like National Center of Biotechnology Information and the Arabian Bioinformatics Institute. And those two databases online, freely, you can go there and access it and download a lot of genomic data that actually uploaded by the researcher across the world and contain a lot of information about different disease, different molecular structure, and different genomic information and molecular data representation. So this is about biological data. Now let's talk about artificial intelligence. And I'm sure everyone here knows about what we mean by artificial intelligence, which is giving the machine the ability to do like several intelligent tasks that a human usually do. And we have inside it like a subdomain, which is machine learning. Within it, we have deep learning, which is become so popular nowadays, which is a neural-based architecture. But if we look at the role of AI in healthcare, so in healthcare, actually the data represent in different representation and different types. So we have demographic information, which is a table representation, clinical notes, which is a text, image, we have signal data, microarray data, genome data. So if we look at those diverse representation of the data, it becomes really hard to build a single model or simple machine learning model to deal with those different representation of the data set. However, with AI, now we can build a model that can take as input different data representation and will give us different outcome based on what exactly we need those model, the purpose of the model, either like for early detection or tumor detection or for virtual agent assessment, drug discovery of or whatever purpose that we are interested in. If we try to put all the story together, like where's AI, big data, and biotechnology came together, so we notice biotechnology is actually nowadays with the existing high throughput technology, similar to DNA sequencing machine, which become really available in a lower cost, we can generate a huge amount of data from the cell. And those biological data, we can then use AI, artificial intelligence technology, to try to understand the different interaction between those data representation and for a specific purpose. For sure, there is other aspect, which is data storage and how we can upload the data to become really publicly available for everyone in the world. But our focus on today's talk is just about biological data, in which how AI can serve in this domain. So now I will talk about two research work that we did at Khalifa University, focused on Alzheimer's disease research. So first, Alzheimer's disease is actually a neurodegenerative, if we talk first about dementia, dementia is a neurodegenerative disease, and it's actually a big umbrella. Underneath it, we have different types of diseases like Alzheimer's disease. So Alzheimer's disease is the most common type of dementia, and it's actually affected patients when there is like 65 years and above. But it's important to know that Alzheimer's disease is not part of normal aging process. It's a disease by itself. And unfortunately, Alzheimer's disease is a complex disease. So the symptom of the disease is different between different patients, different populations. So we have like a general umbrella of how we can manage this disease. So that's why we need some kind of patient stratification to understand like how the disease is vary, and the mechanism of the action of this disease can vary from one patient to another. So if we look at some biomarkers, biological biomarkers that can affect this disease, we can have like mitochondrial dysfunctions. We can have a mutation of the DNA. There are other, for example, there are other environment factors that can cause the disease. We have oxidative stress. So it's not like all the dementia patient will have exactly all those symptoms come together. No, like it's actually differ between different patients. So here, where's like the role of AI, big data, and biotechnology come together. So suppose if we focus on biological data, and I'm talking about molecular data in this perspective, so we talk about gene expression data, SNP data, disease pathways. And we use an AI model because we know AI models can take different data representation and can learn different and complex relation between the data point for different perspectives. So the focus of the work that I will present today is only for early detection and patient stratification using genome data as our base study in this study. So first, when we talk about dementia and why we are really interested in dementia research. So it's important to note that dementia, like early stage dementia diagnosis is really important. And unfortunately, there are a lot of people who live with dementia without being aware they have the disease. Okay, so usually there is a late diagnosis of dementia by 2 to 5 years before being diagnosed, unfortunately. And early stage diagnosis is really important to delay the progress of the disease. And most of the disease diagnoses are focused on invasive, time-consuming, and expensive technique like MRI images, which is not accessible for all people around the world. So that's why we need to keep that in our mind. Unfortunately, also, there is no cure for dementia until now. And the current treatment for dementia is just to minimize the symptom of the disease and try to delay its progress. But it's not trying to cure the system. It's a progressive disease. We can delay it, but we cannot stop it. And 99.6% of clinical try to find a treatment for dementia is failed for many reasons, like we didn't have the right cohort, the disease is a complex disease. The symptoms of the disease is very across populations. So that's why patient stratification or grouping, trying to find people with the same mechanism of action of the disease can help for precision medicine, for trying to find treatment at least for specific cohort based on the disease mechanism of action. And all those challenges actually motivate my research team to focus on dementia. For what I'm going to present here is just focus on early diagnosis and patient stratification. So early diagnosis, again, it's really important. If we realize there is a patient who will develop a dementia beforehand, we can actually delay the symptoms. So instead for him to develop dementia at 65, he can have the symptoms at the 70. Okay, so a part of that, since dementia, there are many risk factors that contribute to it. So understanding this patient will have dementia, we would try to reduce the risk factor that contribute to increase the progression of the disease. And for sure, all this will have a significant reduction in the money that the healthcare can put toward treating those patients. A part of that, as I mentioned, patient stratification. It's Alzheimer's disease as a complex disease. And patient stratification is really, really important toward precision medicine, toward trying to provide the best healthcare planning to reduce the effect and the side effect of this disease on those populations. So that's why the first study focused on using biomarker, and here we're talking about non-invasive biomarkers like blood-based biomarker for early stage Alzheimer's disease diagnosis. And the second study focused on trying to understand disease mechanism of action. And for both studies, we integrated bioinformatic technique along with AI techniques to try to enhance the performance of our models. So in the first study that already had been published, which called a constrained double input deep learning model to identify novel biomarker Alzheimer's disease, we use blood-based biomarker for Alzheimer's disease, and which is a less invasive way of getting information about the patients instead of using MRI and many other invasive techniques. For this study, we actually focus on using Alzheimer's disease neuroimaging initiative data sets. It's a publicly available data set. And this data set is actually rich with diverse representation of Alzheimer's disease information. Like we have image, we have cognitive test, we have electronic health record, genome information SNP. But again, our focus here is to use biotechnology, bioinformatics with AI techniques. So we focus only on the SNP data and microarray data for blood-based biomarkers as a plus-based biomarker for 626 patients. For sure, some of them are normal patients, while others we have MCI and Alzheimer's disease patients. This is the pipeline that we developed. So if you notice, we have like ADNI for sure for some kind of a pre-processing. We need to use bioinformatic technique like Blink to encode the information on the SNP representation to a way that and map the SNP representation to genome map to feed it to the AI model. The novelty on what we thought about, so instead of building an AI model where each node connect and with all other nodes, let's constrain this nodes or the connectivity between gene and pathway based on biological information or biological pathway that already generated by domain experts. And for this architecture, we did that. And we constrained the model pathway using KEGG pathway, which is publicly available, that indicate like how genes are interact for specific diseases. And then we use, at the end after we train the model, we use SHA for model interpretation. And again, we use a string network for pathway enrichment to understand what are the pathway that help the model indicate this patient have Alzheimer's disease or not. In terms of result, our model actually, our constraint, so as our constraint model actually perform better than unconstrained model. So as a benchmark, we use unconstrained model in which the connectivity is like each node connect heavily with the other nodes compared to the constraint model. And we see small improvement here, like not small, it's 5% improvement in terms of the AUC. Look at what have been done about like gene using SNP data and microarray data for early stage Alzheimer's disease detection using the same data set. Our result actually outperform all the what had been reported so far, because again, using genome data to predict Alzheimer's disease is not easy task. For sure, we have other work in which we use electronic health record and image data, and the accuracy is much higher. But here we are focusing to try to understand the mechanism of action of the disease. When we try to interpret the models, we realize like calcium dysregulation are one of the causes of dementia. And dig deeper in the literature, we noticed, yes, this calcium affection actually cause toxic process and oxidative stress on some population, which actually related to neurodegenerative diseases. And we found also mitochondrial dysfunctions, which also have related to neuron damages. And for sure, some pathway that pop up are the depression, which is actually a risk factor for dementia, which makes sense. So from this study, we found those different pathways that indicate the patient will have disease. And the second study, which is like still a preprint, we didn't publish it yet. So in this study, we try to stratify the patient based on genetic information. So again, we focus SNP and microarray data to try to group the patient based on the disease mechanism of action. And this actually can help us toward the precision medicine to assign the right treatment for the group based on the mechanism of the action or pathology of the disease. Okay, so our pipeline focus on use neural network, graph-based neural network in which we establish a network based on the similarity between patient in terms of the probe. Then we use some kind of community detection algorithm to group the similarity between the community. Then we did like...
Dr. Aamna, you have 2 minutes to go, huh?
Okay. Then we have like, we did a matching and we integrate differential gene expression, which is one of the bioinformatic techniques for trying to identify the pathway. And from this result, actually, when we found like, we found different group actually in terms of MCI, cognitive normal and AD. And when we compare like CN with MCI group, we found like 3 subgroups that pop up. All of them have synaptic loss, which makes sense in which they have dementia. Though for the first group, we found DNA methylation effect, which indicate there are external risk factors that cause dementia in this population. There are, the other 2 groups have some kind of viral infection, which we couldn't explain it yet why viral infection pathway keep pop up. And inflammation for sure it show up in all. However, for between MCI and AD, we found 3 different groups. Oxidative damage was one of them, fragmentation the second, and the third, again, we have some kind of viral infection. So from those study and for future, actually from this study, we realized there is a different mechanism of action of Alzheimer's disease across different populations that we will keep investigate further. And for future, we think like AI can be a good a good approach toward developing a novel medication or to slow the progression of the disease using molecular data, again, empowering patient and caregiver, in which integrating the patients in the loop toward how they can manage their health and toward reducing Alzheimer's disease. It's really important. Genetic research is still behind. Like MRI images give a great result, but genetic information is not easy. So it's really important to consider how we can invest more in this action and AI-driven for brain health, for brain monitoring. Finally, AI, big data, artificial intelligence, and biotechnology are really important to be integrated in the right way. So AI need to have some knowledge from domain expert to really lead the domain and healthcare. And for AI, it's really important to reshape complex disease like Alzheimer's disease. So it's important also in our domain to focus that all the development and the technologies, just we need to focus on the people, because we need to focus on improving their life. It's not just about technology in this perspective. Thank you so much. And
thank you very much, Dr. Aamna. Amazing. It is amazing how AI and big data work in biology and biotechnology, where they improve treatment outcomes. Excellent research was presented, such as Alzheimer's disease. Thank you, Dr. Aamna, for this beautiful and wonderful presentation. Now, next, please welcome our second speaker, Dr. Mohamed Almedfa, an accomplished medical doctor from Arabian Gulf University with a Master of Science graduate in Health Technology from the University of Illinois. Currently, he is a radiology resident and demonstrator and internal medicine. Sorry. Dr. Almedfa specializes in healthcare AI, focusing on predictive modeling and decision support systems. He will enlighten us with his speech on overview and future of clinical decision support systems. All the best, Dr. Mohamed. The ground is yours.
Thank you very much.
Yep. Yeah, good to go. We can see it.
All right, thank you so much.
Go ahead.
I just want to start by thanking Her Excellency Dr. Mariam Jalahma for her wonderful speech and for her patronage, and Dr. George as well for his very interesting talk. And I think I can't go on my round of thanks without thanking Dr. Jassim Haji for inviting me. He's not only a friend and a colleague, he's also a mentor to me. And also thank you very much for everyone who's attending, and I hope you benefit from today's presentation. So with all of my thanks out of the way, I think I'll just dive straight into my presentation today, titled Overview and Future of Decision Support Systems, in which I'll talk about what are clinical decision support systems, what are some of their benefits, why are they necessary in this day and age. We'll go over some implementation challenges and then some future outlooks. So what are clinical decision support systems? I got this definition from a bioinformatics book, and basically it states that they are computer systems that provide clinicians, staff, patients, or other individuals with knowledge and person-specific information, intelligently filtered or presented at appropriate times to enhance health and healthcare. So just so that we are on the same page together, I provided here some examples of CDSS, which are available in real world and are seen in many hospitals around the world. And I think maybe physician attendees here might recognize some of these decision support functionalities, which are present in electronic health records that are available in different hospitals in Bahrain. And I think one of the most widely used ones is the medication alerts within the CPOE systems, or computerized provider order entry. So this just basically means that when a physician enters a medication, an alert would pop up showing the physician, for example, that this patient is allergic to said medication, or the patient is taking another drug that might interact with the prescribed drug. So this is just a very basic CDSS functionality that is present in a lot of electronic health records. Some other examples include blood glucose monitoring in the ICU, for example, some clinical guidelines, alerts for follow-up in primary care. And I think something that we see, that we don't see here much, but we see a lot in the Western world is ICD code recommendations. And I think that was proposed and that was implemented because of the many constraints placed by insurance companies on physicians when they try to enter these ICD codes for diagnoses of patients. So basically they come up with CDSS systems that can recommend ICD codes depending on the patient's presentation or the patient's clinical features. Some other examples include documentation aids through prompting systems. So what this basically means is that instead of providing free text entry for physicians, it is replaced with more like drop-down menus or checklists in order to streamline the diagnosis in electronic healthcare records. And finally, diagnostic decision support systems. And I think last year I talked a bit about AI in radiology. So there are a lot of applications in that domain in both radiology and in pathology as well, because they are heavily image dependent, and that's where deep learning can be quite powerful. So what are the types of CDSS? There are many types and many variations in the literature, but I think the most important thing is that we kind of take a broad view of things. And when we take a broad view, usually they categorize CDSS into knowledge-based and non-knowledge-based systems. And I'll go over what that means in a bit. So if you can see here in this diagram, on the left-hand side is the knowledge-based CDSS, and on the right-hand side is the non-knowledge-based CDSS. So what does knowledge-based versus non-knowledge-based mean? Well, knowledge-based, as the name suggests, it takes expert knowledge as its input. So we hard-code clinical guidelines, we hard-code expert knowledge into the clinical decision support system, and then we create rules that can then inform physicians when it comes, for example, to treatment recommendations or diagnoses. And how that works is that we use something called an if-then rule. So, for example, if you can see here in the picture, if pyelonephritis and a pregnant woman, then the system is going to recommend cephalexin as an antibiotic, for example. And if pneumonia and low severity, then it's going to recommend amoxicillin. So it's very manual, sort of rigid system that needs constant updating. But when it comes to non-knowledge-based, which is something that is seeing a lot of traction recently in the literature, and a lot of researchers are trying to implement this in real-world settings, but there is some difficulty because of the black box nature of machine learning models. So here in non-knowledge-based systems, instead of using clinical guidelines or expert knowledge, we're using machine learning models that can take input data and then come up with its own rules in order to provide output to the physician. And I think the problem with that is the nature of machine learning models, in that they are black box models, and they don't really provide reasoning for the specific output. So it will take some input, and then it will give you some output, but you have no idea why it came up with this sort of output. And I think this is something that is going to be worked heavily on in the future, especially now with the introduction of explainable AI, which I'll talk about a bit later on. So what is the necessity of CDSS in this day and age? I think I'll talk about 4 important points, and I'll go over these points in detail over the coming slides. So I'll just skip the slide, and we'll look at the different points that highlight the necessity of CDSS. So the first point is knowledge and information needs, and this kind of ties into the second point of electronic health records, because now with the wide availability of electronic health records, and kind of like how Dr. George said in the beginning, is that now it is mandatory for hospitals to have electronic health records within their system. So with availability of electronic health records everywhere, there is an increasing and ever expanding and growing clinical database and clinical knowledge. And this can be burdensome to physicians in terms of finding the correct and relevant information when it comes to any given clinical encounter. And also because of the constraints that have been placed on physicians when it comes to the time of the clinical encounter. So I think trying to implement CDSS in these settings is going to be of great importance in the near future. When it comes to adoption of EHRs, so EHRs and health information technology in general have been proposed as a solution for rising healthcare costs and quality and safety concerns. And I'll highlight two countries here. I'll talk about the United States, and then I'll talk about Bahrain. So in the United States, for example, there was the Institute of Medicine reports, and there have been many federal public policy efforts, such as the American Recovery and Reinvestment Act, and also the Medicare Access and chip reauthorization. So all of these reports and these public policy efforts have mandated and have advocated for the use of electronic health records in hospitals. So how did that influence the adoption? So as you can see here from the Office of the National Coordinator for Health Information Technology, on the y-axis is the percentage of adoption of EHRs, and on the x-axis is the year. So you can see back in 2008, around 10, it was in the range of 10 to 20%. But then as we reached 2021, we're in the range of 80 to 100% adoption across all hospitals and across office-based physicians as well. So there has been massive uptake in electronic health records. And in Bahrain, there has been a proposal for the need to implement EHRs in 2009, and also then the founding of IGOAI, which is the very popular electronic health record here in Bahrain, which you can see in Salwani and other healthcare centers. And this was part of Bahrain's health agenda in 2011 to 2014. And NHRA also established a national good documentation practice policy in 2020, which just tries to standardize and help with the documentation of clinical data and electronic health records. So how does the EHR landscape look like in Bahrain? So as out of 18 surveyed hospitals, very promising results, 89% of hospitals owned an EHR. Of which only 16 had a comprehensive EHR system. And if you look at the image on the right here, it shows you the different classification systems for electronic health records. And comprehensive, meaning that it contains all of these important subcategories of electronic clinical information, CPOE, results management, and decision support. And then you have the basic EHR with clinician notes and without clinician notes. So most of electronic health records actually are not applicable, meaning they cannot be classified even as a basic. So they are inferior to basic EHRs. And around 33.4 had a basic EHR with clinician notes. And when it comes to decision support, around 42% of hospitals had a clinical decision support functionality, with the most common one being the drug allergy results, 13 hospitals having that specific functionality. And I think the only negative point to take home from this study is that there are 13 different electronic health record vendors, which might pose a big challenge when it comes to interoperability, right? So for example, when a patient is going to a specific private hospital or even a healthcare center, and then he is referred to another hospital, he's going to have trouble with taking his data from that hospital to the next hospital. That's why patients often need to print their results or print their clinical notes and take them to another hospital. So I think having a unified sort of electronic health record system is going to go a long way when it comes to making the patient journey a very easy one across our healthcare system. The third point is personalized healthcare services, and Dr. Aamna talked a bit about genomics. And I just thought I'd highlight this graph here from the National Human Genome Research Institute to show you why there is a current paradigm shift when it comes to a heavy focus on personalized medicine and on genomic medicine. So in 2001, you can look at the cost of sequencing the human genome was a very astronomical number, actually. But nowadays, in 2022, it is less than $1,000. So with all of these capabilities and all of these advancements in technologies, it has become much easier to incorporate genomic data into electronic health records. And this is what is happening right now in the United States. So for example, there is this very famous electronic health record vendor called Epic, and they partnered with Foundation Medicine in order to come up with clinical decision support systems that can cater to the incorporation of genomic data into electronic health records. So what are the benefits of CDSS? There are definitely a lot of benefits, and a lot have been explored in the literature, such as reducing morbidity, minimizing errors, improving physicians' diagnoses and treatment recommendations, which overall increases the quality of care, and also reducing the cost of care. So now that we've talked about that, let's talk about some challenges. And mainly the two challenges that are on top of each other here are kind of related, when it comes to fragmented workflows and alert fatigue. Both kind of happen because of increased cognitive load on physicians from trying to interact with different systems or trying to interact with a lot of pop-ups or a lot of alerts that can cause alert fatigue and also increase cognitive load. And I certainly hope that I haven't increased your cognitive load today with my presentation, and I hope it has been very easy to digest. But this is what often happens in healthcare, because you're looking at different systems, you're looking at a lot of alerts that can pop up, and physicians can become desensitized to these alerts and can potentially ignore them when they are important and need to be addressed. So some potential solution for that is proper integration with electronic health records and also participatory design of clinical decision support systems. So involving relevant stakeholders like physicians into the design of these systems. And also system and content maintenance is a challenge, and a potential solution is sustainable funding to update these records and update the knowledge that is embedded within these systems. And finally, validation, which a potential solution for is regulatory frameworks. And I think we've heard some very promising news, I think a couple of days back, when the European Union have agreed on a deal to regulate AI in their countries. And this is definitely something to look forward to, because while it may not have been implemented, it might be implemented somewhere around 2025 if voting goes through early next year. But definitely other countries in the world are going to follow suit if that goes through. So definitely something to keep a lookout for. So what are some additional challenges of non-knowledge-based systems? Because they use machine learning models, data quality becomes an issue. And that is why there are a lot of efforts to standardize the language used in electronic health records, such as what I've explained earlier about NHRA. And there are also a lot of things in the Western world, such as, for example, something called the SNOMED CT, which basically standardizes the language used so that we can use that free text more efficiently in coming up with our machine learning models. And then explainability is also a problem, because if the physician is essentially a translator of medical knowledge to their patients. So if they can't explain the output of a machine learning model, then that's going to be very difficult to implement, because physicians aren't going to trust these systems. So explainability will become a very, very important thing in the near future, and it is already gaining traction. And there are a lot of research papers on how to make these machine learning models explainable. And then finally, also interpretability by physicians. So potential solution is education of AI literate clinician workforce. And I think this is one of the things that the Arabian Gulf University is trying to work towards with the introduction of computer science courses for year one students in the university. So what is the future is going to look like? Like I said, we're going to focus more on explainable AI models. And basically what that means is that we'll want to take these black box models and make them explainable. And there are a lot of explainability methods that I won't go through for the sake of time. And also trying to create white box models. So that means creating more simple models like linear regression or logistic regression, which are inherently explainable. And also promoting fairness and restricting biases and discrimination, analyzing sensitivity of model predictions. So to conclude my presentation, I think CDSS, like we've talked, can improve the quality of care by various ways. And future research and work should focus on transparency and explainability of models to ensure stakeholders' trust in these systems, and so that we can efficiently implement them. Regulation is another important aspect that needs to be addressed in the future, especially here in the GCC. And I think that looking at the study earlier, when it comes to the EHR landscape in Bahrain, Bahrain is definitely well equipped to utilize clinical decision support systems. But I think the problem here is that there are a lot of EHR vendors, and I think maybe standardizing that or trying to unify the electronic health record system used in Bahrain is going to go a long way in making our healthcare systems much more efficient. And then finally, and I think in my humble opinion, to reap the full benefits of CDSS, I think it's crucial to adopt a developer mindset rather than a consumer one, specifically with electronic health records. Because if we have our own electronic health records, then we can sort of take that feedback approach loop of taking the data that we get from our electronic health records and then trying to reuse that and trying to improve our own systems. And then for example, coming up with these clinical decision support functionalities is going to be much easier if we are the one developing these electronic health records, because the integration is going to be seamless. And I think with that, I end my presentation. Thank you all for listening, and I hope that you benefited at least for a little bit from this. Thanks.
Thank you very much, Dr. Mohamed. Thank you. Amazing. Successful distilled complex information into concise points. You have demonstrated a clear understanding of overview that you have done and the future of clinical decision support system. I like that. I like the way that you have done the comparison, and also the challenges that you have highlighted in this field. Thank you very much. It has covered the broad range of topics accurately. Thank you very much for your participation. Now, let us move to our next speaker, and let us warmly welcome Dr. Shujaat Khan, Assistant Professor in the Department of Computer Engineering at Dhahran KSA KFUPM, with a background as a Senior AI Scientist at Siemens Medical Solutions, USA, and a PhD in Bio and Brain Engineering from KAIST, South Korea, University. Dr. Khan brings over a decade of machine learning expertise. Wonderful. His impressive portfolio includes international patents and more than 50 peer-reviewed publications. Dr. Khan's research spans machine learning, optimization, and signal processing, particularly in biomedical and bioinformatics applications. He will now share with us his insights on his presentation, which is titled Transformation, Diagnostics, and Treatment. Please welcome with me Dr. Khan. The ground is yours, Doctor.
Thank you so much. All, I'd like to thank you for the invitation. And I saw first two presentation, they've been very nice work, and my work is also related to those, but from the engineering point of view, like what we can do in the engineering perspective that can expedite the utilization of AI for healthcare. So in today's talk, I will cover some of the applications of AI in the area of medical imaging and bioinformatics, and how AI is actually transforming the diagnostic and treatment. I'm also the fellow at JRC AI, and here I'm also working on one bioinformatics project, so I'll give a brief overview about that one as well. So we know that the AI can actually help us in many ways. Like it can help us in improving the early diagnostics. It can also help us in improving the medical imaging, for instance, in the detection of tumor, in analyzing the image, and also in the design of personalized. My work is actually around these areas, and as the last speaker mentioned, we need to also think about the ways through which we can regulate AI so that we can harness the best for the community, not just like developing a business, and because if it's unregulated, it can be a trouble for the future. So my actually area does not include that part, but obviously I'm interested in this, so ethics of AI as well. So just a brief overview of my work in the area of medical imaging. This is actually my main area, and I work on different modalities in the medical imaging, ranging from X-rays, CT to ultrasound imaging. And I was fortunate enough to work with highly talented people, and our group was first to actually design the AI-powered efficient beam mode ultrasound imaging for variable subsample imaging. And again, we are fortunate to produce some novel techniques which are among the first in this area. And after my PhD, I joined Siemens Healthineers, where I was working on the distortion correction for tissue imaging, which is very amazing technology and essential for the diagnostic of abnormalities in the brain. So this is just a kind of a brief picture about the work span. So in today's talk, I will focus only on the ultrasound imaging, because even if you talk about just one modality, there is actually a lot of things that we can discuss. So as we know, the ultrasound imaging is one of the safest imaging modalities and has been in use for decades for various applications, ranging from echocardiography to fetal scan. And because it is considered so safe that we can use it for the fetus, and but there is actually this issue. If you compare the quality of ultrasound, it's very poor compared to CT, X-ray, or MRI. So there is a need for the reconstruction quality images, but if we the conventional way is to use expensive systems, and not just only expensive, but we need bulky systems. But when it comes to the 3D ultrasound, the complexity multiplies and goes exponentially. So there is a need for the reconstruction of high quality image, but with using the reduced number of measurements, so that we can design ultra fast, portable, and high quality three-dimensional systems. So in this area, the work that I mentioned was among the first, is related to the beamforming in ultrasound imaging. In conventional beamforming pipeline, the image formation pipeline, we acquire data with the help of probes and goes through some signal processing steps like beam focusing, beamforming, envelope detection, low compression, and it generates low quality image if you have subsample or low, like a the number of measurements, if the number of measurements are low. And this is just a pictorial view of what signal processing steps are involved here. So conventional beamforming pipelines are simple, but they suffer from different artifacts due to the signal loss. And the only way, the standard way to improve the quality is to increase the number of measurements, which eventually increase the cost and the size of the system, so make it slightly inaccessible. And beside this poor quality, there is actually also a demand for the low-cost system, so that we can improve the accessibility to the region. So my work in this area is related to like replacing this conventional pipe with the intelligent pipeline. With the help of AI, we can actually improve the quality, and by using even the reduced number of measurements, so that we can design low-cost system. So the first work that I did was related to designing a standard beamforming technique, which actually take measurement data and produce high-quality image. And it's the only issue with this kind of system is that if you need different type of output, for instance, despeckled, deconvoluted, or other kind of contrast, then you need a separate deep learning model. So on the hardware side, yes, it reduces the complexity, it reduces the required number of measurements, but actually it increases the complexity on the side of the deep learning because you need more models. So to resolve this issue, I proposed this idea called switchable deep beamformer, where the objective was to use the single model, and just like a ultrasound probe, where we switch the mode of operation here, we take one input from outside, and we want our model to be adaptive enough. So if we change the type of desired output, same model can generate different out. This help us reducing the complexity, because again, the complexity of the model also required complex hardware. So and interestingly, this actually produced amazing results for us, and the study was published in TMI. Both studies were published in highly reputable journal in the area of ultrasound and medical imaging. And as mentioned by the previous speakers, that in medical imaging or in medical or healthcare sector, the application of AI is actually is need to be scrutinized based on its explainability as well. It's just like it's not like something, a black box model which is generating something out of blue. We need to explain that why it is doing it. So for that purpose, the study was I mean, we unbox our model and we drive one theory for optimal transport-based style transfer, which is related to adaptive instance normalization. And we show that, like, if you have, for instance, content and a style, with the help of ADA-in, you can map this style on the content. So our model actually work on the similar principle, where we take the signal and we have different styles available, and we actually try to map those style on it. So these are the results, and because it's the screen is very I hope I can show you the Zoom version of it, slightly zoom in. So you can clearly see the difference between the proposed one and the conventional approach. So the proposed model improve the quality and work for different styles. This is really helpful in designing the improved system. I'm working on one more project related to ultrasonic imaging, and in this project, the objective is to take one step, like using the AI one step further. Like the operation of ultrasonic imaging system is slightly complex. It required constant input from the sonographer side. So the experts are needed even if you have the high quality system, you need well-trained staff to produce high quality image, and it's actually very tedious job. And also, there are some steps involved, like once you have high quality image, you acquire it, then you have to evaluate the quality, and you have to assess whether the findings are there or not. And sometimes it's a cyclic process. You acquire multiple frames and multiple scans, and then you go through all the frames. So it's inefficient in a sense of time, cost, and you require trained staff. So inspired by this idea, we first actually designed this speech recognition module that takes the human command, like for example, here actually these are dummy commands, but we can actually introduce more commands if you like. For instance, if you want to reduce the blur or increase the resolution or suppress some artifact, we can, during the scan, we don't need additional ends to control the device. You can just simply speak it into the mic, and the system automatically recognize the commands. Then actually we use BERT, or it was BERT, the language model, and then we generate this encodings. Interestingly, the initial idea was tested on the small data set and show promising results. With the speech, we can actually control the image quality. So here are some examples, like if you speak, like increase the blur or increase the resolution, reduce the noise, and something like that. So this way we can utilize AI and make an end-to-end system, which not only improve the quality, but through AI we can also control the system. And final objective is to use the AI to assess the image quality. And all these works are actually done not just alone with the here actually we're taking feedback from the clinicians, and they find this idea very interesting, and I'm hoping that it will soon be available for the demonstration. So this is the one work that I'm currently working on. The next is the AI in bioinformatics. This is to improve the treatment, because the imaging is good. Imaging is essential these days for the diagnostics, but for the treatment, we need some drugs and medications. And obviously, there are a lot of areas to which you can search for the solutions, but I find the protein sequence classification and peptide sequence generation is one interesting area, and here the AI can really help, especially if we can design some explainable generative models. So we can reduce the search space for the novel candidates and novel chemicals that can help us in treating the drugs. So in the area of the bioinformatics and analytical chemistry, actually work on different applications ranging from the improvement of reproducibility of the system, especially in spectroscopy. We know that this is very promising technology, but it suffers from the reproducibility because signal is very noisy. Similarly, in the area of explainability, we need more statistical tools that can actually filter out the information and remove the clutter and provide us a better picture, unbiased picture. So these are some areas, some of my work related to this area, but one specific work that I want to talk here is related to the peptide sequence classification, especially not only the classification but also the generation. So this is another project that I'm working on with the JRCII, and here the objective is to design novel candidates of anti-cancer peptide. So as you know, the proteins are the complex biomolecules, and they are like a they are actually everything for the cell. Like if they are involved in the process of body formation, repairing, growth, or signaling, and various processes are actually governed by the proteins. And the application of proteins are not only in the area of drugs, but we can use the novel proteins to design new materials and other industrial applications. For instance, if we design AFP, antifreeze peptides, proteins, they can help us in cryopreservation. If we work on ECM, extracellular matrix protein, they can help us in identifying the structure of the cell and so forth. So we know the proteins are actually important, and the conventional way of identifying a protein, like let's say if you have a sequence, or if let's say you know one process and you want to identify what other proteins can perform the similar operation, the conventional wet lab based methods are very expensive, very time consuming, and they are unsuitable for the large scale operations. So here AI can significantly reduce the cost and expedite the process of identifying novel candidates. And why? Because AI, with the AI, if we train the AI on some patterns, like for instance, if we take a FASTA protein sequence and we train a model, then during the inference phase, this process is just this can be done in seconds. But if you compare it to the conventional MATLAB-based method, it required several iterations of experimentations, and this is why it is quite expensive. But these processes are considered gold standard, whereas the AI-based techniques are they are moderately accurate. So we need some ways through which we can improve the accuracy of the system, but also make the system explainable, so that we can use some information from the AI experiments and then expedite our gold standard experiments. So we identify some novel candidates from the AI and then perform some clinical test or the wet lab-based test to identify whether these candidates are really what the AI is saying. So in this direction, I'm actually working on unboxing the deep learning model, and the technique that I propose called deep LSE. And this technique actually it's based on the idea of regeneration, like generative modeling. So it not only perform the classification like conventional methods, but it actually regenerate the input. And for instance, if you are aware of autoencoder, so here we actually projected it in the latent space, and the latent space have certain constraints through which we can control, okay, which part of the distribution belong to ACB and which part of the distribution belong to non-ACBs. And once the model is fully trained to produce these kind of latent space, we can use generative model to use samples from, and we can do random sampling and generate novel samples. So now these novel samples are like a most likely candidate for the ACB activities, and we can use the similar process for other proteins, other peptides, and we can cascade different model to reduce the candidates, because this is random generation, so we can generate as many candidates as we want. But at the same time, we know that these candidates are they have a high likelihood of having the characteristics that we are looking for. So this is another nice application of AI which I'm working on. So that's all from my side, and thank you so much. I would also like to thank my my professor and my collaborator, Professor Zhong Chilye, and some of my collaborators from the NCI, and they are actually all over the world, and I would like to thank them. Thank you.
Thank you very much, Dr. Khan. It's amazing how engineering is an integral part of the AI mechanism. Amazing, amazing. How AI, machine learning, NLP improve early diagnosis with medical imaging. This is something I know about it actually. I have read lots about it, and I have done some research about them. How AI and bioinformatics accelerate the new drugs development and treatments also. AI boosts early cancer detection and does lots of things. Engineering is a vital component when you are doing AI researches and development. Thank you very much, Dr. Khan, for your speech and presentation, and it was a valuable contribution. Now, you can leave. That's okay. Now we will go for our next speaker. Please welcome Sheikh Abdullah Jamal Muhyiddin, the Data Governance and Engagement Manager at Sheikh Shakhbout Medical City. Sheikh Abdullah is boosting. Sheikh Abdullah is boosting over 20 years of experience in healthcare, IT program management, data science. You are like me then. And analytics. He is seasoned expert in cancer and epic systems. Sheikh Abdullah is recognized for exceptional leadership and successful project implementation. He has led significant data analytics initiatives and major health care providers across the Middle East and the US. Now, data analytics is something very, very important in AI and AI field, and that's why I'm sure that this presentation, and among same as the previous one, it will be very informative and very helpful. Today, he will enlighten us with his speech titled "Transforming GCC Hospitals with AI." I wish you all the best, Sheikh Abdullah. The ground is yours.
Thank you for the wonderful introduction. It's sometimes nice to listen to these introductions. Man. So let me get started. IT. I think the one word that we all need to look to automate is can you see my screen? Am I audible? Right. I wish there was some.
You're audible, and the screen is on. Go ahead.
All right. Great. Just give me a moment. Yeah. Thank you so much. So as we discussed, right, Bob, I think I see the following 20 minutes as a discussion of what all the previous esteemed speakers have spoken about. I think we spoke about a lot of models, a lot of applications, but in my speech, I really want to kind of extend that into how to kind of adopt that artificial intelligence to kind of transform the hospitals across UAE and GCC. All right. Again, the themes we would talk about. We spoke a lot about AI, but how do we kind of take these lab stuff into the adoption journey, and what did we do to take this adoption journey at SSMC? Again, SSMC, if you would allow me, we are a three-shield organization. We are one of the largest hospital in the UAE, 760-bed facility. We are a three-shield organization which represent clinical practice, education, and research. The clinical practice drives the research and education. Research is defined by the physicians in practice. and the education needs are determined by the by our workforce, depending upon the needs of the institution, right? So these are the themes that we will go across in today's discussion. What do we need to consider for the provider market, and how does the future of AI in hospitals look, right? So before I begin, do we all remember IBM Watson, right? If you can recollect IBM Watson garnered very significant interest, right? I mean, at that time, I think I was in my college years, early college years. So there was a lot of hype about IBM Watson. There used to be a lot of articles, and especially in healthcare, it was deemed the next big thing and the next transformative, disruption that's going to happen in the healthcare industry. But unfortunately, it faced many challenges and it failed, right? I think it was there was overpromised and undercommitment. IBM Watson did not have a lot of data feeds. So everybody expected IBM Watson to work out of the box, right? Which it did not, obviously, for obvious reasons. Because in healthcare, as we all understand, there is a patient dimension and there is a personalized medicine dimension. I think that context was missing, and then it required a high cost and tech requirements. So which the tool that was marketed as the revolutionary fell short of expectations, majorly because it did not provide an accurate and reliable advice due to the complexity that involved in the individual cases. What is in, we need to be honest, right? There is some kind of an inconvenient truth about AI, right? AI, ML, and digital health environments are all kind of are in a limbo when it comes to their ability to transform healthcare delivery, right? I mean, they show huge potentials in lab, but when it comes to the actual delivery, I think we are still facing a lot of issues there, right? And then this kind of emphasizes in the digital transformation. It's not the technology, right? It's not the technology that's going to drive your delivery. The whole of digital transformation and AI is about the people who are responsible for AI in the organization, right? And how do they manage the pan-organization change management? I think that's what is a very key necessity here, right? Again, these are some of the leading vendors, right? Watson, Microsoft Health Vault, Verily, Amazon Care. These all was deemed as the next big things, and it kind of failed, right? They were either forced solutions, ineffective partnerships, and people were expecting a lot out of them, and lack of data, right? I mean, lack of data across. They were all trained in a specific training data set, and it did not work through, right? Amazon's sorry, the slides keep going over. Yeah. Again, Amazon Care, again, a biggest example of how in healthcare silos will not work, right? And Amazon Care tried to do a whole ground up model, and rather than kind of tapping it in the existing ecosystem, right? So what did we learn from these failures, right? So we kind of had established a very early AI strategy, right? We not established an AI strategy, but we understood there is a need for an AI strategy by kind of managing our early adopter demands, right? So we had three teams in large, like where we had a clinician-oriented AI, the patient-oriented AI, and operation-oriented AI. I think as some of the previous esteemed speakers spoke about, we kind of started off with the diagnostics and pathology solutions, which are FDA approved. So that kind of brought in the necessity physician buy-in. I think Dr. Cheriyan also in his speech touched about how physicians were agnostic to technology and all that. So building trust was very important. And I think by bringing in trusted solutions as early adopters, we began kind of building that ecosystem where the physician trust was beginning to show, and the AI was rather than trying to do something new, started we kind of highlighted how it could perform the mundane tasks, right? The repeated tasks that people do, and how it could help the physician save his time to focus on more important things. So we started off with the diagnostic and pathology stuff, and then later moved to the operations oriented AI, which you see is a no-show optimization that we are currently undergoing. Again, an example of what we implemented and what is the outcome. So GI Genius is a gastro-related AI model, which kind of again used for the colorectal neoplasia, right? I mean, there was the colorectal neoplasia, it kind of missed this kind of 8 hours of video and hardly 10-20 seconds of the relevant images, right? And to spot that, physician had to go through, or the radiologist had to go through such detailed videos. But by using the GI module, or the GI intelligent endoscopy module, we were able to bring a twofold reduction in the colorectal neoplasia, right? And we got a paper published by Dr. Michael Wallace, who heads the OPS committee, the outpatient committee for us at SSMC, in terms of what is the impact. So slowly, the physicians themselves started talking about the impact of having an AI, and they were kind of asking for the next opportunity, looking for the next opportunity on where they can kind of bring in AI to kind of help them, right? So that gave us an armor in our arsenal to kind of go and establish this, right? Today, we are Abu Dhabi's first dedicated. We have the Abu Dhabi's first dedicated clinical trials unit. We have partnerships with Khalifa University. Dr. Aamna was here earlier speaking about some of the models. We have partnership with the Sheikh Mohammed bin Zayed University of AI, the Oxford University Hospital, and we have the first Department of Health. I mean, Department of Health is a regulatory organization in UAE, in Abu Dhabi, for machine learning. And we kind of have a wide array of AI research initiatives, right? Some of them on the EG, pulmonary embolism, point of care ultrasound. I think the importance of ultrasound was emphasized by Dr. Shujaat Khan earlier, right? On how very safe it is. So we're focusing a lot on POCT ultrasound tests and acute kidney injury, which is one of the leading causes of death here in Abu Dhabi, right? So what did that lead us to, right? Today, kind of healthcare, right? Healthcare alone generates 30% of data across world, which is currently generated, right? So that means we had to focus very early at having a very establishing the governance and leadership. As I mentioned earlier, it is not purely about the technology, but it's about the people who are responsible for implementing AI and driving AI. And how do we improve the data? I mean, this problem is a perennial problem, and I'm sure most of us here would resonate, right? And we all hear these terms as junk in and junk out. You only get what you kind of what you put in. So how do you essentially improve the data? Can you use kind of different mechanism to kind of address the fundamental issues before talking about very jazzy in the lab AI models, which never see the light of the day. In my past experience in the last 3 years, at various organizations, I have developed around 8 models, except for one model, all were in lab. They've won many awards, many recognitions. You would see them in conferences, World AI Show, Arab Health, but nothing to transform the healthcare in the hospital, except for the one which is a no-show model, which we are currently working on. And third, it's very, very essential to foster an ecosystem, right? Ecosystem internally within the organization, and kind of ecosystem to build it outside, right? The way we've built ecosystems around the research and education and the AA partnerships that we have. And fourth, most important stuff, right? How do we manage this change? How do you manage this change? How do we execute it? How do we kind of manage the demand, delivery? How do you measure? How do we make sure that whatever we are doing is worth the effort of doing? Because these are massive transformation projects that we are undertaking, right? What has been our AI journey so far, right? So as we spoke, we kind of supported early adopters in terms of diagnostics, research, and operations. Then we kind of move on to solve the strategic problems of the organizations, right? Which could be, my ROI needs to improve, my patient experience needs to improve, my surgery conversion rate needs to improve, and kind of then you drive the health system's improvement. And as a health system, how do you drive improvement across, right? So, and those were our kind of driving north stars to deliver the transformative AI solutions, right? And how do we do that, right? Using data and AI governance. Again, the importance of governance around data and AI cannot be understated anytime. Developing the necessary ecosystem and investing on the infrastructure. Again, finally, the project management, change management, and execution that we spoke about. What has it been so far for us, right? Through the data governance, right? And when we began the data governance council, we kind of first identify the gaps, the data fragmentation, the lack of trust in data, and lack of access to data, right? And those were the three main problems that we kind of identified. And when we kind of put this framework together, we said, okay, what are the immediate outcomes that we are expecting, which is enhanced business intelligence and decision support systems, as Dr. Mohamed emphasized on how important it is to have a very robust decision support system, and how many of the hospitals, in spite of having a EHR, do not have a robust clinical decision support systems. Which includes your clinical and operational aids, and then the population health insights, right? And then our long-term goals were becoming a very data-centric organization, where data drives what problems we are trying to solve. Data drives behind what should be our strategic teams for the next 5 years, for the next 10 years, and bringing in the AI readiness, right? I mean, I have consciously used the word readiness because every department within the provider network, or every subsection or every specialty needs there is no one size fit all kind of a situation here, right? We need to cater to very focused, customized demand, and that's why we call it being AI ready across these sections and specialties. And then the third, the most important, clinical and operational excellence. That kind of drives our bottom line, right? How are we doing at the end of the day? Are we doing clinically well, or are we able to sustain that using our operational excellence? All right. Then how is this enabling the data strategy at SSMC? So we have put in a two-phase approach, where phase one is all about having an AI committee which is focusing on handling the demand, focusing on handling what people are asking, how do we crowdsource ideas, what are the areas that are actually going to be impactful in the healthcare delivery, right? And then how do you kind of bring in the policy and foundational leads, because there are a lot of ethics and models in whenever we work with data, not just develop models, right? When we are working with data, we have a responsibility, right? And the more the data, the more responsible you become. And then phase two is to establish an AI center of excellence, which will focus on strategic solutions and development of further infrastructure and research. So the outcome from the phase one expected was AI adoption, as we mentioned. How do we adopt these models, and how do we bring in the change management, right? So again, what does the adoption journey look in? How does the adoption journey need to be, seamless or frictionless, right? So first, it starts with the identification of need. Then we kind of seek the vendor solutions or take a decision on, do we need to implement in-house? Because as like we spoke, again, interestingly, the no-show model, right? I mean, there are at least 4 no-show models that I've developed in my career for different organizations, and even within the same city, different hospitals did not work with a similar data set, right? I mean, you had to do a lot of customization, a lot of tailoring, and hardly these healthcare providers were just kilometers away, right? Because the population pyramid of each hospital is very unique. Right, there is a government sector, there is a public sector, there is a community center. So these need different kind of implementation strategy, and then kind of develop our vendor negotiations, facilitating approvals. I think that's another important stage where we kind of lose a lot of time. And I don't know. I would like to ask the question that maybe if we can create a tool to automate this approvals on the ethics committee, on the IRB, and stuff like that. Probably, I'm not sure if that would kind of reduce our cycle times, right? And then we kind of move ahead to pick up one specialty or department where we pilot this, show the outcomes, and spread by kind of publishing it across the organization and kind of commercializing it, right? That's really your data monetization, right? When you commercialize it, that's your data monetization. Commercializing here doesn't mean that you have net to net dollar value for every data attribute that you have in hand, but look at the amount of data that has been generated in the past few years by physicians, right? And they've been, I mean, there are regulations, there are political environments, economic factors. You need to document this, you need to document that. There is, if you are in an insurance kind of setup, then there is a pay necessity. But this is the time that, for us to give it back to them by, monetizing that data for them to, kind of make sure they are focusing on the right things. Again, what does that mean? At SMC, we built a strategy projects and analytics office. I'm part of that office, where we kind of make sure the project management is done. We have the process improvement. We do an implementation support. We do the change management and analytics. So it's a full suite of services that we provide to the organization as part of the SPA, as we are called. To kind of to drive, right? And we go in and see what data tells us, right? And where is the need? And our office kind of identified that the data improvement and digital information, digital transformation was required, across these 3 areas, which is 4 areas, right? Which is people and culture. Surprisingly, 47%, changes were required in the people and culture, 33% on the process improvement, 10% on data and technology, and 10% on strategy. All right. So this kind of re-emphasized that the people quadrant, you can never move away with it, right? We all talk about people, process, technology. We focus on technology. We focus on process. But what do we do for people is the most important stuff that's going to keep us going forward, right? Again, in terms of that leads to kind of what are the opportunities for hospitals in 2023, right? I mean, 5 areas that are identified across, I think, by some market research and aligned to our SSMC findings as well, is how do you improve your hospital workflows, right? How do you manage the imaging and diagnostics, right? And how do you kind of bring in that context, right? The personalized communication, virtual care assistance, inpatient surgery and workflows, right? So these are the 5 areas which in my opinion, I feel that will provide a lot of opportunities for hospitals, especially now with ChatGPT, right? I mean, any AI conversation these days does not go away without mentioning ChatGPT and generative AI in general, right?
Mr. Abdullah, can you hear
So
me?
how is it going to impact, right?
Hello?
If you really see the generative AI, so on different technologies, right? On from 1 million to 100 million users, the turnaround time for ChatGPT is really disruptive, right? And it's really transformative, right? You see that what Netflix had, what Facebook had, what Instagram had, close to 1,000 days. ChatGPT is not even there, right? I mean, there's no
Hello,
competition for
Mr.
generative
Abdullah.
AI. So
Hello?
the adoption is humongous. There's a lot of lot of interest in that. I think hospitals will be able to unbox the opportunities there in those 5 areas to begin with. And this is an interesting question that often comes about, right? And John Ives is one of my favorite researcher, right? So there was a talk that is AI going to replace physicians and all that, right? And
Mr.
John
Abdullah.
Ives had mentioned that the chatbot
Hello?
responses were even preferred over physician responses, and they were rated significantly very higher, right? And hospitals do run the risk of displacing of administrative workers, and kind of if you have a limited data, I think that's where the integration of data and making sure you have a very robust data feed mechanism is going to be crucial. We run into the risk of bias, and of course, creating synthetic data, right? The false data, which is so much easier with a kind of a tool these days. So these are the
Mr.
three
Abdullah, can
challenges
you
that
hear me? Hello?
that are there as risk for hospitals. But in general, what we believe is that the generative AI will provide opportunities for providers, to create, personalized care pathways, right? I think chatbots can. Hello?
Can you hear me, Mr. Abdullah? I'm talking to you for for 2-3 minutes now.
Hello? Can you hear?
No. Can you see me? Can you see me? Can you see me? I'm the moderator, Ahmed.
Hello?
Hello? Yes,
Hello?
Mr. Abdullah, I think you passed your time by 3-4 minutes now, and I'm trying to talk to you for more than 3-4 minutes. You're not listening, hearing me?
Yeah, I now I can hear you. Can you hear me?
Now I can hear you, yes, because I was trying to talk to you, but I mean, you are not hearing me. It seems to me you're
Yeah,
not
for
hearing.
some reason, yeah.
I
Yeah,
don't
for
know
some
what's wrong.
reason.
I don't know what's happening. Anyway, you exceeded your time by almost 3-4 minutes now. So if you can
Oh,
wrap it
sure.
within a few seconds, please. Can you go ahead in a few
Yeah,
seconds?
sure.
Wrap it.
Sure. So again, chatbots will be there to enable us provide differential diagnosis and kind of help uh, physicians accelerate their ability to provide care. Right. Again, the sweet spot of AI, make sure it's driving value, having better outcomes, and ethically and responsible AI. Right. Quality, safety, and operational excellence as quadrants. Again, key messages: adopt a strategy that emphasizes on data foundation alongside strong governance. Generative AI will definitely transform care delivery. We need to make sure the providers are eventually kind of embarrassing it and making sure that they are ready for the change. And focus your AI solutions on the mundane, right? Fix the little things, fix the small things, and so that we can focus on the next big thing. Thank you, and I'm sorry for kind of going over time.
No,
Yeah.
that's fine. That's fine. I'm sure there is some glitches in the technology. At the end of the day, as it works fine, it sometimes gives a hard time for everyone. Thank you very much, Mr. Abdullah. I mean, actually, you have demonstrated some critical aspects of how AI and is transforming the GCC hospitals. And we noticed, I mean, everybody noticed how essential is that to have good experience in data analytics to improve our medical services. This was a fantastic presentation. Thank you very much, Mr. Abdullah, for your valuable participation. Thank you very much. Now, before I go for the next speaker, which is our fifth speaker, I would like, we forgot to thank our the organizer CEO. I would like to thank Mr. Tushar Sahu, CEO of Global CIO Forum and the organizer of this event. and his team for organizing this lovely AI and healthcare event. Mr. Tushar efforts is bringing together industry experts and fostering meaningful dialogue have been commendable. Thank you very much, Mr. Tushar. Now, let us go for our third speaker. Yes. Okay, we are honored now to introduce our fifth speaker, Dr. Iman Mohamed Khurshid, the assistant professor in the Department of Mathematics. I love mathematics at the University of Bahrain. Everything is about math. Dr. Khurshid, who holds a PhD in statistics from the University of Bath and a professional certificate in data science from IBM, is a distinguished member of the University of Bahrain Strategic Plan Preparation Committee. She has been a fellow of a higher education academy since 2011, an elected member of the International Statistics Institute since 2021. Her research spans the application of AI and data science techniques in diverse sectors. Dr. Khurshid will now present her insights on AI models vs machine learning aided model for severity prediction of COVID-19. I wish you all the best, Dr. Iman. The platform is yours. You can switch on your cam.
Thank you, Mr. Ahmed, for introducing me, and thank you for also inviting me to be a speaker of the second virtual summit on AI in healthcare.
Can you, Dr. Iman, can you just bring on your camera a little bit higher because you're not visible properly?
Okay.
Lower, so your face become more visible. Yeah. Yes, great.
Is it better now?
Yes, yes. Thank you very much. Thank you. Can you also, presentation, so I can confirm to you that we are seeing it, so you can continue. Yep, we can see it. Go ahead.
Okay, thank you. Okay, my talk is about artificial intelligence models versus a machine learning aided model for severity, a prediction of COVID-19, which is a population-based study carried on University of Bahrain. The agenda is I'll start with an introduction and then introducing the methodology that have been used in this study, followed by COVID-19 severity risk prediction models and results, and finally a conclusion. During COVID-19 pandemic, early identification of patients at high risk of COVID-19 severity was an urgent need, not only to define the clinical and epidemiological characteristics of the disease, but also to adapt an optimized treatment protocol for delivering high-quality medical services and achieving better healthcare outcomes. The identification and importance evaluation of potential severe COVID-19 risk factors was pivotal for guiding health sectors to provide the best medical care, improve infection outcomes, and allocate appropriate resources at all stages of the disease. Some demographic features were reported with high association rates with COVID-19 severity, and a key factor among these is older age. In addition, comorbidities such as cardiovascular disease, diabetes mellitus, chronic kidney, and certain blood disorders may predispose COVID-19 patients to an elevated risk of intubation and death. And despite the US reports, the literature lacks sufficient population-based studies that support these determinations. And furthermore, the correlation between COVID-19 severity and some potential factors are still under investigation worldwide. So the aim of this study was to build population-based prediction models with artificial intelligence and machine learning capabilities for predicting COVID-19 severe cases based on a set of potential demographic and clinical characteristics risk factors, and compare the performance of the developed prediction models, and finally to conduct sensitivity analysis on the developed classifiers to gain some insight into the relative contribution of the considered factors in order to predict patients at high risk of severe COVID-19. The methodology that have been followed in this study started with identifying COVID-19 patients and collecting data and then describing the data. So a sample of 205 individuals were infected by COVID-19 between 15 of March 2020 and 31st of March 2021 in Bahrain is considered in this study. Bahrain citizens form 85.4% of the infected participants, and the remaining were foreigners residing in Bahrain. The mean age of the participants was 40 years old. And in figure 1, we can see that the groups that have been included in this study, where we can see that 40% of these individuals were below 30 years and 44% are between 30 and 50 years or 59 years old, and the remaining, which is about 16%, were 60 years and above. In the present study, COVID-19 severity is defined as follows. Those patients who were hospitalized in the hospitals with acute dyspnea, low oxygen saturation level, need for mechanical ventilation, or even intensive care unit ICU admission, beside those patients that have already died. The severity potential predictors and response variable. We have here to discuss more about the predictors that have been used in our models. So in this study, we have 10 risk demographic and clinical factors potentially responsible for severe illness of COVID-19 were examined. And the demographic factors were mainly age and gender. The clinical factors were diabetes, obesity, asthma, cardiovascular disease, neurological disorder, cancer, hypertension, genetic blood disorders like G6PD, SCD, and thalassemia. And the response variable was COVID-19 severity, and is categorized into 2 levels. The first level is the non-severe cases, and the second level is the severe cases, and these were labels with 0 and 1. Here is some descriptive statistics of the COVID-19 data. We can see, for example, that we have around 48% males and 19% were diagnosed with diabetes mellitus, and 22% with hypertension, 31% obesity, around another 20% asthma patients, 4.9 or approximately 5% cancer, and around 11% with cardiovascular disease, 2% with neurological disorder, and around 24.5% genetic blood disorder. While some infected individuals experienced only mild disease, there are 126 cases of the 205 participants encountered complicated symptoms of COVID-19, of which 40 patients could not even survive. we are going to speak more here about the severity risk prediction models. So on this research, we developed an artificial neural network, ANN, model for predicting patients at high risk of severe COVID-19 using a training data set which included 70.6% of the observations, that is equivalent to 145 patients of the 205 patients included in the set, and another testing data set which included about 29.4% of the observations, which is about 60 patients. For comparison purposes, another logistic regression model and a random forest model were also developed by utilizing the machine learning tools available in the statistical software that have been used in this study, which is R. The first model is the artificial neural network COVID-19 prediction model. Artificial intelligence has been widely used in the medical sector since the last decade to develop complex and non-linear models. And classification in artificial intelligence is actually a data mining problem of assigning new observations in a data set to target categories based on a training set of observations with known classes. So in this study, a nonlinear ANN prediction model was built using the multi-layer perceptron MLP algorithm. The second model that we have developed is the logistic regression prediction model. Logistic regression is a statistical classifier that can be utilized to predict a binary response variable from a set of continuous and categorical data. In this research, a logistic regression, LR model, supported by the machine learning tools available in R, was developed for predicting risk of COVID-19 severe symptoms in terms of values of the 10 considered potential risk factors. As in the ANN approach, the training dataset was used to generate the model, whereas the testing set was utilized to validate the model. The third model is based on a random forest technique, where we have developed a random forest COVID-19 prediction model in this study. So decision tree is a class of supervised learning algorithms that can be utilized for classification with categorical variables. It mainly operates by creating multiple decision trees at the training stage to output an uncorrelated forest of trees that represents the mode of the underlying individual decision trees. In this study, a forest of 500 decision trees with 3 randomly selected predictors as potential candidates for each split was considered using the machine learning algorithms to fit an optimal random forest model for COVID-19 severity. The results. An ANN model was developed for predicting COVID-19 severity. The classification results of this model were compared with those of a logistic regression model and a random forest model. The predictive performance of each classifier was assessed based on accuracy, sensitivity, and specificity. Sensitivity and specificity evaluate the prediction of binary classification models, while sensitivity measures the rate of positive cases that are correctly identified specificity measures the rate of negative cases that are correctly classified. Here we'll speak about the prediction evaluation for our models. The prediction results, as you can see, are displayed in table 2, where you can see that the first column displays the ANN results, and the second column displays the logistic regression results, and the last column represents the random forest column. So based on the training data set, the ANN model achieved an overall prediction accuracy of about 85%, with a sensitivity of about 86% and a specificity of about 83%. The overall prediction accuracy of the LR model was found to be slightly lower, which is around 83.3%, with a sensitivity of 83.5% and a specificity of 83.1%. The random forest model achieved an overall prediction accuracy of 81.4% with a sensitivity of 83.2% and a specificity of 78.6%. At the testing stage, the ANN model achieved an overall prediction accuracy of about 85% with a sensitivity of about 87.8% and a specificity of about 78.9%. The LR model produced predictions with an overall accuracy of about 71.7% and a sensitivity of about 80.5%, but a much lower specificity of about 52.6%. The RF model achieved an overall prediction accuracy of about 71.7%, a sensitivity of about 65%, and a specificity of about 82.6%. By comparing the testing data results with those derived at the training phase, it is noticed that the prediction accuracy of the LR model of mild cases becomes significantly lower, while that of the severe cases remained high. Unlike the logistic regression model, the random forest prediction accuracy of the mild cases increased, whereas that of the severe cases decreased. These changes in performance have declined the overall prediction accuracy of both classifiers, namely the logistic regression and the random forest regression, by approximately 10% each. However, the overall performance of these two models remained relatively good, with an identical accuracy score of about 71.7%. On the contrary, the ANN model predictions remained stable and scored a higher overall accuracy of about 85%. Thus, the AI-ANN model is considered the best model among all developed models in this study. Sensitivity analysis can be defined as the study of how a response variable of a prediction model is related to and influenced by the independent variables. It has been widely used for identifying the degree to which each variable contributes to the identification of each class of the response variable. In Table 3 and Figure 3, we are going to present the sensitivity analysis performed in this research. Table 3 shows the factor importance and ranking of the 10 predictors for the ANN, LR, and RF models, where we can see, for example, that the ANN model has rated age as number 1, with a percentage of about 20.9 in terms of importance, followed by asthma and cancer, obesity, blood disorder, gender, diabetes, cardiovascular disease, hypertension, and finally, neurological disorder. While the logistic regression model has ranked age again as number 1, asthma as number 2, and then blood disorder with a percentage of about 19.3, followed by obesity, gender, diabetes, neurological disorder, hypertension, cardiovascular disease, and finally cancer. The RF model, again, has ranked age as number 1 in terms of factor importance, followed by asthma, cancer, obesity, diabetes, hypertension, gender, cardiovascular disease, cancer,
دكتورة
and finally
إيمان دكتورة إيمان
نعم.
باقي دقيقة ونص باقي ها؟
Okay, I will finish now.
Wrap up, yes, please.
Thank you. So the sensitivity analysis displayed in Table 3 has revealed that older age, active asthma, followed by cancer in the ANN approach, or genetic blood disorder in the LR and RF approaches, and obesity in this order have highly dominated the predictions, the ANN, LR, and RF classifiers, with total factor importance scores of about 61.5%, 77%, and 74.3%. Most of these findings were consistent with the results obtained in some previous studies. Now, although the LR model considered the group of patients with blood disorders at elevated risk of COVID-19 severity, the normalized variable important percentage shown in Figure 3 moderately ranked this factor in the AI approaches, namely the ANN and the RF. The later results are in line with some available studies on severe COVID-19 symptoms in SCD patients and several reports. Male gender appears to have more influence on aggravating the severe symptoms of the infection than the female sex, and this result is again consistent with several other studies available in the literature. Diabetes, mellitus, cardiovascular disease, and hypertension have revealed how to moderate influence on the development of COVID-19 severe outcomes, and the current results are supported by some existing studies. These unexpected relationships can be attributed to the prevalent and strong associations between such disease and aging, where older age was ranked as the most influential factor on COVID-19 severity by all three models. A factor that was found to be weakly significant in predicting COVID-19 by all the approaches is the neurological disorder. However, this may be dominated by the small portion of participants affected by the disease, which is about 2% in the data. The results reveal that older age is by far the most important severity risk factor, although the vast majority of researchers have not considered asthma a risk factor of COVID-19 severity. All the generated models in this study have ranked this factor the second most influential predictor. The innovative potentials of the artificial neural network and the random forest artificial intelligence technologies, along with a machine learning aided logistic regression technique, were utilized in a field of healthcare to predict COVID-19 severity in relationship to 10 potential risk factors and to gain insight into the relative influence of each factor on the risk of adverse COVID-19 complications. With the aid of the available innovative AI technologies, COVID-19 patients that are at elevated risk of progressing to severe infection can be early identified to receive spot treatment and medical rapid care. Further, health professionals can take fast and appropriate actions to better control the severe infection and more efficiently manage the available resources for an improved provided healthcare quality and outcome. The results of this research reveal that the ANN model performed best in terms of classification accuracy. This may guide future researchers in selecting the best artificial intelligence approaches for modeling and predicting events of interest. Thank you for your attention.
Thank you, Dr. Iman. Thank you very much. I mean, actually, you have provided an outstanding demonstration on AI and machine learning. The demo highlighted the role of technology in predicting diseases, such as especially showcased the prediction of COVID-19 using AI models. So we are thankful. Thank you very much, Dr. Iman, for your insightful and informative presentation. Thank you very much. All right, now we go for our next and final speaker, which is, let us welcome our final speaker, Mrs. Mariam Al-Abbad, highly skilled data scientist specializing in AI application and healthcare. As a key member of the data science team at King Faisal Specialist Hospital and Research Center, Mrs. Mariam has led transformative healthcare projects. She is an expert in machine learning and deep learning. So we are talking about an expert in programming and AI, where she has developed and implemented an innovative AI solution addressing various healthcare challenges. I wish you all the best, Mrs. Mariam, in your presentation, and the floor is yours. You can share your presentation, and then let me make sure that you are. Yep.
Okay, thank you. Thank you for your introduction. Okay. Can you see my screen?
Yes, I can see your screen and you're audible. All the best.
Thank you. Okay, so hello and good afternoon, everyone. My name is Mariam Al-Abbad. I am a data scientist working at King Faisal Specialist Hospital and Research Center, based in Riyadh, in Saudi Arabia. Before I start, I would like to thank the organizers for giving me the opportunity to participate in this conference, where I will speak about how AI is applied here in the hospital and present some example use cases that we have successfully developed and implemented. Okay, so first let me brief you about the hospital. So King Faisal Specialist Hospital is one of the leading tertiary care hospitals in the Middle East. And it is operational in 3 regions, Riyadh, Jeddah, and Medina. It was established back in 1975, and it aims to provide the highest level of healthcare and best patient experience. It offers highly specialized inpatient and outpatient medical services across different fields. So we have cardiology, oncology, organ transplantation, and more. It provides comprehensive advanced care to both local and international patients. And the hospital also has a strong emphasis on research and innovation. So here are some numbers from last year's annual report. You can see we have growing numbers in the number of patients, referrals, surgeries, and so on. And the hospital, King Faisal Specialist Hospital, is recognized internationally for its excellence in healthcare. And as you can see here are some rankings that the hospital has achieved. As you can see, most of them are related to organ transplants. Since the hospital demonstrates a commitment to innovation and the integration of cutting-edge technologies, it established the Center for Healthcare Intelligence, aka CHI, in 2019. CHI was established to promote the cautious adoption of AI and emerging technologies for transforming care development, delivery, and operations. So in CHI, we build and deploy innovative and value-driven systems that touch patients, clinicians, staff, leaders, and the whole community. This is achieved through harnessing the power of best practice AI and its latest technologies and fostering national and international collaborations and maximizing the return of investment. So to drive the success for CHI, we are committed to these guidelines or components. And to achieve the optimal outcomes, we follow a unified workflow for use case selections based on the business value, the feasibility, the targeted consumers, and the dimension that the use case contributes in. For us, AI and machine learning use cases can play a vital role in three main dimensions. The first dimension is operational intelligence, which includes monitoring, automation of hospital processes. And the second dimension is quality of care, which includes preventive care, diagnostic and prognostic use cases. And the last dimension is experience for the overall hospital experience for both patients and staff. And we will like different use cases for each dimension shortly. So once a use case is selected, it goes through a thorough and detailed process of execution, starting with feasibility analysis, which includes gathering the requirements, checking the availability and quality of data. And after the prerequisites are met, then we proceed with development phase, which is followed then by validation and deployment. So this drives us to the operations part, which is a critical phase where we seamlessly integrate the models into the deployment environment and infrastructure. And during this phase, we focus on constructing robust and efficient data workflows effectively. And also we communicate the predictions with the relevant stakeholders conveniently. And after that, we employ continuous monitoring to track the availability and performance of each model. And we also facilitate ongoing learning and improvement for existing models where we compare the predictions with the true values or the ground true values when they're available. So of course, our patients' privacy is our priority. So we maintain the patient's data internally, and we use a wide range of techniques to protect the data and prevent exploitations. We also follow a scientific approaches to provide explainability to our model's results. This is to promote transparency to our stakeholders. And also, given that the healthcare sector is critical and the results can impact patients' lives. And so we're very careful about this point. So at the Center of Healthcare Intelligence, we have an exceptional team of AI talents who are responsible for development and the deployment of the majority of our use cases in-house. However, we do collaborate closely with external institutions and universities, but mostly our team collaborates closely with domain experts here in the hospital to ensure highest quality of solutions. So we're very eager for partnerships to achieve the best business benefits. So now I will go to present our use cases, some of the use cases that are developed here in the hospital. First, let me just mention that we here in the hospital, we present our AI use cases to stakeholders using our internal platform or our internal AI platform. It's called Dhahran, which derives its name from the Arabic word eye. So Ain is accessible to all staff inside the hospital. So it provides a centralized hub for sharing information. However, access is restricted and to specific use cases. only to the involved parties. This is to ensure governance and data protections in the hospital. Okay, so let's go to the first use case in the first dimension, which is experience. Okay, so we have this project called Untitled. It is basically an AI predictive tool that utilizes advanced machine learning algorithms to predict patient satisfaction and the probability of appointments no-shows. This enables us to identify patients who are likely to miss their future appointments and those who may have a negative experience. So by analyzing historical patient data and feedback from various sources, the system provides valuable insights that allow you to enhance the patient experience and reduce no-shows. So the healthcare providers, they set an action forum. So basically, they set actions that they can implement to prevent the bad experience that the patient may have. So for an example here, so let's go back to the dashboard. So here, when for example, the nurse views this table, so the staff member can see, can spot exact patients who may have bad experience. And then once they click on the row, they are redirected to an actions form. So this actions form basically is filled by the nurse of whatever actions that they may do to prevent the patient from having a bad experience. And then the results are shared with the experience office. This is to address patients' concerns proactively. So, okay, and also the list of patients who may have a high probability of no-shows are shared with the communication team. This is to notify them of their appointments beforehand. So there are major benefits of this project. One of them is to enhance patient satisfaction scores, and we have seen an enhancement by over 10%. So this is based on a monthly average. And also we have high utilization of this tool, which is great to see. And also we have reduced no-show statistics. The second use case is within the operational intelligence. It is a tool for to view the situational awareness. So it's basically for the oncology department. It shows the overall situation of the department, the number of inpatients, as you can see here, the number of readmitted patients, and the number of discharges, as you can see in the chart. You can see the discharge timeline, so how many discharges were done this week and how many admissions were done this week. And also you can see here the white bars represent the prediction for future days. So for the next 3 days, we are predicting the number of patients of admissions, and we also are predicting the number of discharges. And as you can see, we have a live view. So for example, this dashboard was it's today's view, basically. So you can see, for an example, in the discharge timeline, we have Wednesday, December 13th. We're expecting about 12 discharges, and we already have 1 discharge today. So this is to assess our tools and to help the staff to evaluate the overall situation. We also have the orders table for the inpatients. So any orders that may have delayed the discharge of certain patients are displayed there. And when the user clicks on the exact catalog. For an example, the laboratory orders for the current inpatients, you can see like the most pending orders, basically. So the oldest pending orders. And the user also can see the staff load. So based on the position of the physician, you can see how many patients he's currently handling. And the user also can filter the entire dashboard. So he can select a certain medical service, for example, or a nurse unit, and then the entire dashboard gets updated with the relevant information. So the next tool is to predict the length of stay for ICU patients. So this is basically an advanced predictive analytics tool that utilizes machine learning algorithms to accurately predict the duration of patient stay in the intensive care unit. It is based on historical data from previous ICU admissions to identify factors that may impact the length of stay and generates the calculated prediction for each patient. So again, this is a live view for today. For example, this is the list of patients. You can see the MRNs on the left are hidden to preserve our patients' privacy. But you can see here the currently admitted patients in the ICU and their expected discharge time exactly. So you can see we first categorize the patients who to two categories, basically for short length of stay, who will stay 3 days or shorter, and then we have another category for long length of stay patients. All the present patients currently are of the short category, but there are some days where we have patients who may stay longer. So this model basically enables healthcare providers to optimize resources allocation and improve patient outcomes by identifying and addressing potential delays in the discharges process. And we have achieved substantial benefits from this use case. We have reduced the length of stay by 60% to around 4.5 days for certain ICU patient population, so a subset of them. And we also enhance the ICU service utilization through increasing the volume of transfers. So the next use case, again, from the operational intelligence, is the pharmacy volume forecasting. It is one of the use cases that have highly helped in increasing the efficiency of our pharmacy resources, so including staff and medications and the scheduling. So when the availability of staff and so on. As you can see, we have the predicted number of incoming orders for each pharmacy in Riyadh and Jeddah currently, and we're planning to expand this use case to all branches. And you can see here the prediction on the left and the live view of the actual values, so the true values on the right. Next, let's move on to care quality. So this is one of the proactive diagnosis cases. It is basically breast cancer risk assessment. So this model, it enables targeted screening strategies to achieve earlier detection for breast cancer patients. So based on the patient's information and family history, the available scan, and all of this information, we can give a prediction for a single study, whether this patient may have like high risk of developing breast cancer, or specifically malignant breast cancer, in the next 5 days. And we categorize the studies based on like low, moderate, or high. As you can see here, we have the list of patients. Again, the Amarans are covered for patients' privacy, but you can see here, for example, I have the second case selected. You can see in the chart where it's located compared to the population. So this is the chart, and when you click on the scan, you can view the scan for this selected use case. So this is one of our preventive care solutions to reduce the risk of harm screening and like in the future. Okay, so our next use case is for abnormal chest X-ray.
Mariam, you have 2 minutes to go, inshallah.
Okay, no problem. So this will be my last use case, and then I will conclude my presentation. So there are around 5,000 chest X-rays, chest X-ray scans done per week in the hospital. So with this large volume of scans, it is hard for radiologists to identify and prioritize abnormal scans. So in this project, we developed a tool that helps them to go over the high priority or the cases with high priority first that may have like specific conditions. So this highly helps in like going over the scans or patients that may have complications than others. Okay, so this is the last use case. We have liver segmentation. So automated liver segmentation, as you can see, as you may know, like radiologists take a long time to quantify the volume of liver. This is needed for liver donation. So this is used to assess the whether the donor is able to perform liver donation. So we have created this tool which substantially decreased the time to measure the volume of the liver. And all of our solutions are completely applied and used by the hospital staff. So it was my pleasure to present to you our applied use cases in the hospital, and I hope it was insightful to you. Thank you all for listening.
Thank you very much. Thank you very much, Mrs. Mariam. Wow, mashallah, mashallah, la ilaha illallah. Mrs. Mariam's presentation on the application of AI at King Faisal Specialist was an eye-opener, actually. This is how you see how you get benefit out of AI and the new technologies, the disturbing technologies, showcasing the innovative strides the hospital is making in healthcare is tremendous. Thank you very much. It's clear that the hospital is enhancing patients' care and setting benchmark for others in the region. Thank you very much. It was a valuable contribution, Mrs. Mariam. Now, yeah, I think we have some time to pose some questions for the speakers. If I would kindly ask the speakers and whomever on the stage to switch on your cameras, please. Yeah, everyone, all of you, just switch on your cameras. If you don't mind. Okay. My first question is for some of them are from the audience and some of them, I mean, from it's a general practices. For Dr. How can AI and big data together accelerate the biotechnological advancement in healthcare? How can AI and big data together accelerate the biotechnological advancement in healthcare? Mike is yours.
Okay, so big data, like in bioinformatic, biotechnology field, we have a huge amount of data exists. Okay, especially in terms of RNA sequencing, DNA sequencing, and as I mentioned, we have NCBI and those data that contain already diverse representation of the data set for specific disease. So if we manage to find a better way to integrate this different data representation of a specific disease in a more comprehensive model, it will help us to understand the disease. It will help us to treat people in the right way and for early diagnosis and many other healthcare applications. So there where AI can help in which by integrating this diverse representation of the data in one comprehensive model.
Have you done this, or you have planned to do this in the future?
Actually, I have done that, and we have a several paper under review yet about we trying to integrate like clinical information with genome information with MRI images, and the accuracy of the model are really great. But the issue is we notice like the most important variable that indicates the patient is have AD or the stages of the dementia, either like they have early stage dementia or late stage dementia, focus on a clinical information or MRI images. Okay. However, like the contribution of genetic information is really still small. That like we need to invest more research on how we can extract useful information from genetic information because it exists on.
This is great. It's great. Yes, it's great. And I'm happy to hear that. I mean, it's amazing how the region is moving towards quickly and accelerating these things. Okay, thank you very much, Dr. Aamna. Let me go for the next to save some time. Dr. Khan, can you give an example of how AI has changed the approach to diagnostics and particular field of medication or medicine? Can you give an example of how AI has changed the approach to diagnostics and particular field of medicine as per your presentation? I'm just focusing on what you have presented, so I'm giving you a question based on that. Yes? Dr. Khan, can you hear me?
Yes. I'm sorry, actually, there was some.
Can you hear the question? Did you hear the question?
Can you repeat it again?
Yes, please. Okay. Can you give an example of how AI, because you talked about the engineering thing mostly, an example of how AI has changed the approach to diagnostics and particular field of medicine?
Yeah, there are actually a lot of examples, especially in medical imaging. If you see in a recent decade, especially in MRI, actually MRI imaging is heavily rely on AI technology. This deep learning boost is quite recent, but if you go back, let's say 10 or 15 years back, there are actually classical AI techniques that are playing significant role. For example, in the acceleration of MRI. MRI usually takes a very long time to generate full image, and we are actually noticing that with the advent of AI-based techniques like even the classical one, like GRAPPA and other compressive sensing-based techniques, the scan time has been reduced dramatically, like several times, like 10 times and 20 times. And the quality of image has been significantly improved. So this improvement in the image quality, as well as the reduction in the scan time, help us to diagnose more patient, and also it provides convenience to the patient. Like imagine if you are in a machine for several minutes in that confined area. So it was impossible for many people to go through this experience. Now with the reduction in time, they can be scanned, and similar improvement has been seen in ultrasound. Now we can actually predict the predict the growth of the fetus quite accurately, And this also helps us in taking decisions, necessary decisions, which are essential for saving the life of babies. So the AI isn't used, especially in imaging, I can say, from my experience and from the colleagues I heard, that the success of AI is there, and they are really noticing it in working.
I know that because I've done it lately. The MRI takes between 30 to 45 minutes. Now, how much time saving you're talking about here?
So even actually, the 30 minutes time that you mentioned, it's even actually after the classical AI. Imagine if you remove it, it may take even longer. So the conventional imaging techniques require full scan, and the classical techniques that help us in designing a practical system are also based on the AI. Like, but with the more advanced technology, like the deep learning based model, we can reduce it down to, let's say, 2 minutes. There are actually.
Wow. That's great. Imagine those machines where sometimes you need to put your head inside. Some
And
people
actually,
cannot hold it.
And I'm not talking about the kind of research in the laboratory or something. It's like a real, I mean, the manufacturers design these machines, and hopefully it will be available for the large population in a relatively cheap cost. So that's another factor that we need to consider, because it provide accessibility to those who cannot afford, such a. So this is one application, but again, in the patient-specific treatment, like anti-cancer peptides, so you can design patient-specific drugs. And obviously, this one, I'm not actually, I don't have many success examples, but it is in process, and there are actually promising results from different levels of the experimentation and trials. So not on the FDA approved side, but their initial clinical trials actually show quite promising results on that direction as well.
Yeah. I'm imagining that it's a promising field, and I think that it will be something wonderful in the future. What is coming is much more than what we're seeing now. Thank you very much, Dr. Khan.
Thank you.
Mr. Muhyiddin. Now this question is for you. What's this one major challenge? I know that you have said some challenges, but just tell me one for you. What is the most important and major challenge GCC hospitals face in adopting AI, and how can it be overcome? Switch on the mic, please. The mic.
All right. The biggest challenge is going to be the people quadrant, right? People culture and our habits, right? Because that I personally, in my humble opinion, do not think that technology will have the challenge that in kind of adopting AI in hospital space, but it's going to be people and how we kind of when it comes to AI, I see there are two kind of people's emotions, right? One group wants to use it, wants to leverage it, wants to kind of see how it can be beneficial. On the other side, there are people who are very skeptical about it. Is it will it make my job redundant kind of perspective? So I think there are two kinds of perspective there. I think the biggest challenge is to kind of to educate them, make them AI literate and AI aware on how AI can be an enabler in their work or in their clinical practice, to kind of give faster and very precise care. I think some of us spoke about precision medicine, having the novelty of treating every patient individually, creating care pathways. I think those are the things that we need to do, but we need to go back to the board to fix one problem at a time. What is it the physicians are bleeding today, and where AI can fix their job? What is it the administrative people are bleeding today, and how do we fix that? And what is it the patients need? What is it that they do not like, right? And what maybe it's patient experience. Mariam showed a beautiful AI model on how they're using patient experience to predict no-show, right? And something of that sort to kind of get what patients need, right? Or what is the level of, are they happy with the care? Are they happy with the waiting time? So the people's quadrant is, I think, will be the major challenge. which if we focus, we can just make the AI adoption in healthcare space, especially in the provider space, a very disruptive adoption.
Thank you very much. Thank you very much, Mr. Mohamed. I have a question from one of the audience, Dr. Mohamed, for Dr. Iman. Are there any study measure patient trust and satisfaction of using AI and telemedicine in managing their illness? Are there any study that measure patients' trust and satisfaction of using AI and telemedicine in managing their illness?
Well, I think there are many studies in the literature. I have listed some of them as references in my talk. So if the person who was asking, I can provide him with
Yes, please.
some of these papers.
Okay, so I will ask the person from the organizer to send you the message, and you just answer it, and he will reply back to them. Okay. With that, I still have a question for you. I have a question for Mariam. I'll come back to you because you didn't answer. Because I have a question for you, Dr. Iman. But let me ask this question to Mariam. Mrs. Mariam, for the breast and chest, do you use just hold on, Dr. Mariam, for the breast and chest, do you use your own produced AI algorithm, or you work with any specific vendor? Okay. For the breast and chest, do you use your own produced AI algorithm, or you work with any specific vendors?
Thank you for the question. No, our algorithms are developed in-house by our team. And they're mostly constructed of unique pipelines that are specific for our use cases.
Okay, so you cannot. It's only for the hospital itself, yeah.
Yes, exactly. It is. It's built using our own data from King Faisal Specialist Hospital.
Okay. Thank you very much. I will be having one question for each, and it's a common question. You have 1 minute to answer, but first I have this question for Dr. Iman. What are the advantages of using AI models? What are the advantages of using AI models over traditional machine learning models and predicting diseases such as COVID-19?
Well, as you have seen in the study that I have conducted, I have found that the AI model was performing a little bit more accurate in terms of predicting and in terms of forecasting. And I think all these statistics that have been shown in the presentation just shows an evidence for the power of the AI models.
Okay. I have this question for all of you. It's a common question. You have 1 minute to answer. Now, you are a consultant who has been hired by hospitals in your area, in your region, in your country. And they told you that they want you to go in front of the CEO or the chairman of that hospital and give him one advice how they should move with their future plans regarding AI. So what would be that? Dr. Aamna, you first. 1 minute, huh?
Okay. So the idea is experts in the loop. We always need to have the physician in the loop for any AI model. This is my my advice.
Okay.
Always should be there. It's not like AI can give us a perfect answer.
Thank you very much. Dr. Khan?
Actually, my suggestion was actually just for like we should also include AI scientists whenever there is some data. So we should actually keep record of like data, because data is so precious and we are wasting it. Like X-ray images, CT scans, MRI, all sort of data. We should design some kind of way through which we can save and make it accessible for other future research.
Yeah, thank you very much. Mr. Mahideen, your mic. You either make it on all the time or you forget.
Yes. Yeah.
Please go ahead.
I think next I'll develop a model when somebody calls my name, my mic will go unmuted automatically.
You have to do that.
So it's going to be a bonus. I'm going to give you 11 advices, not one. Okay. So first one, I would say educate and train our staff, focus on collaborative AI systems, build patient-centric AI applications, consider ethical considerations and bias, invest in research and development, have patient and staff engagement, invest on infrastructure and resource allocation, focus on regulatory compliance, and look out for the changes that are coming from government, and build strategic partnerships, and patient at the center always.
Thank you very much. Lovely. It's lovely. Dr. Iman?
Yes, I think one of the main problems that we researchers face when we deal with such problems is the lack of data. It is not easily found, and it took from me, for example, a long time until I get all this data. So I think if people who are managing the hospitals and they have some certain problems and they would like us to provide them with predictions, is to provide enough data and make it accessible for the researchers in order also to help them to answer their questions. So for example, I think one of the things that have been mentioned by Her Excellency Dr. Mariam, like that she would like to know, for example, prediction, or she would like us to help in predicting the amount of medicine that should be available, for example, in the pharmacy. So for us, in order to help this hospital or to help the government to answer such question, we need data. So making data available is really a very important part in research. Yeah, I think.
Okay. And I agree with you 100%. Data is the most. No data, you don't have AI. It does not work without data. Yeah. And big data. You need the big data. Yes. Thank you very much. Yes, Mrs. Mariam.
Okay, great question, by the way. My advice would be to first and foremost set clear goals of what you want to achieve in order to have clear measurements. So basically, it enables you to measure the results of the AI that you have built, because building AI without utilization is just a waste of time and resources and data as well. And so the first thing I would say to set clear goals that can be measured.
Thank you. Thank you very much, Mrs. Mariam. Now, before I just do the closing, I would like to answer this question even in 30 seconds. I'm a consultant, so when I go for companies and managements and sit with them and talk with them, I just say one thing. Technology is just a tool, regardless of the type of the technology. AI has nothing to do with programming or coding or these things. AI is about something called adaptability. You have to adapt the innovation that is coming in. So technology is just a tool. Digital transformation, regardless of the technology, specifically using Industry 4.0, is all about leadership mindset. The leaders, they need to change their mindset, and they have to adapt what is coming in, and from there, they know how to set their plan and roadmap and move forward. Thank you very much for your being with us. And as we draw this AI in healthcare virtual conference to a close, I would like to thank the audience for your active participation and for being here with us until this time, and to our distinguished speakers for their invaluable contribution, Dr. Aamna, Dr. Mohamed, Dr. Khan, Sheikh Abdullah, Dr. Iman, and Mrs. Mariam Al-Abbad. Your presentations were enlightening and instrumental in advancing our understanding of AI in healthcare. Your contribution also are greatly appreciated. Thank you very much. Also, thank you very much. And also with the guidance of the patrons like Her Excellency Dr. Mariam Al-Jalahma, and the insights from thought leaders like Dr. George and Dr. Jassim Haji, which I'm expecting to say a closing message after I finish. We are stepping forward into a future where healthcare is transforming by technology. Let us carry the momentum from today's enlightening discussion into our collective efforts to enhance patient care. Thank you again for joining us, and may our path cross again to further this vital dialogue. Thank you very much. Dr. Jassim, if you have any closing, we will be closing now within 1 or 2 minutes.
Assalamu alaikum. I probably don't have much to add to our distinguished speakers and our prominent moderator to what was said, and the support of the health sector in Bahrain, from the executives to the higher authorities. I also want to mention His Excellency Sheikh Mohamed bin Abdullah Khalifa, who is the chair of the Supreme Council for the Health, and he's always supportive of all these technological solutions. I would like to thank again the speakers. I know a couple of them came back for the second year to speak about it, and thanks for them. And the rest, and hope to expand on this event, which was successful with your presence. Thank you all again.
Thank you very much, Dr. Jassim. And we will close in 1, 2, 3. Thank you very much.
Thank you.